This afternoon we have a presentation on the update on the three branch institutes and the West Virginia CANs. We have a speaker, Carolyn Bowling, Secretary, Department of Health and Human Services. Would you like to come up front? Nice to have you today.
Well, thank you, Madam Chair. I appreciate the opportunity to be here. This is actually an exciting day that I'm able to talk about something that I have very strong feelings about, and that's children and families in the state of West Virginia. And I think that you'll be very pleased with much of what I'll be speaking about today in terms of our strategy for how we're going to improve the services to children and families. I'm going to start with talking about something that has been in place since July of last year, and that is the Three Branch Institute. The goal of the Three Branch Institute was really to focus on social and emotional well-being of foster children. And it was sponsored by, as you can see on the screen, multiple agencies, and we were able to bring a team of individuals together that included two members of the Legislature, Senator Unger, who's, I'm sorry, can't be here today, as well as Delegate Perdue, and others have participated on an ad hoc basis as needed in the Institute. But the whole goal of this Institute was really to talk about how all three branches of government can work together to help our foster children. And it really does take all three branches of government. It really does take everyone sort of focusing on doing the right things for our children and families, and how we can go about doing that is critically important. When we engage stakeholders from the judicial system, the legislative system, the executive branches of government, we really have all the players at the table to really discuss collaboration and cooperation about how we go about changing things and changing our system in the state of West Virginia. The goal, of course, is to provide better outcomes for children, and that is really the focus of the Three Branch Institute, and we are very dedicated to that process, and we're 1 year and a few months into it, and we have really already made some significant progress. Now, here are some interesting statistics that you need to be aware of and why it's necessary to look at changing the child welfare system. What we learned in the Three Branch Institute is really state comparisons in terms of how do we look compared to other states in how we manage and deal with foster children in our state. And this particular graph really talks about children that are in care. That is, children that are removed from their home and in some type of foster care. And if you look at the national rate is 3.3, we have the highest rate per capita of any state in the United States, which means that we are more likely to remove children in per capita than any state in the United States. So that was a real indicator for all of us that we need to look at change. We need to do something differently, because we all know that children do better in a home environment. It's very critical, because if you look at the research, it will tell you their emotional and social well-being is impacted by removal, and is impacted by removal multiple times, which occurs in our state, and it also is an indicator of the future success, that child's ability to do well in the education system, that child's ability to be healthy and really be able to focus the attention on those children going forward. And we know that those children are the workforce of the future. So it is very important that we think about what is it that we can do to create stable environments for children. The second indicator that we looked at and compared ourselves to other states is very concerning, because it talks about children in congregate care. What does that mean? That means that we're talking about children who are put in a residential placement for care. So again, the red line indicates how likely we are in the state of West Virginia to remove children and put them in congregate care. Now, there's a couple things to know about congregate care. One is, no matter how hard we try, you can't make that a home environment. It is different from being with grandma. It's different from being in a very good foster home. It is different from being in a home where you're getting support services with your natural parents. Congregate care is good for certain types of children and necessary, but certainly when you look at our statistics and our comparison to the national average, you can tell that our children are in congregate care, and we have to determine why is that occurring and what alternatives might there be to congregate care for children. Understanding that safety is always first, that we have to factor in the safety and well-being of the children, but minus that piece, if we know they're safe, what is it that we can do to keep children in a home-like environment? Because every time we remove children, the children go through trauma. And our system has to be a trauma-informed system. We have to understand what that does to the child, what implications there are in terms of how they feel and their emotional and social well-being, and how that impacts their health and well-being. We looked at these statistics for the 3 branch and we said to ourselves, we now need to do a deep dive and an analysis of why. Why is this occurring in our state? And more importantly than anything else, what can we do about it? What can we change to make it better? How can we improve the system? Now, we felt like one particular area that we wanted to focus on as part of our 3-branch initiative is to make sure that we were screening these children timely when they were removed, so that we understood what services do they need, what specifically can we do for these children quickly to ensure, again, they're safe, they're healthy, and what other types of services might be necessary to either maintain them in their home or to help families cope with and deal with some of the trauma that may have occurred with the child. So we have put in place a mechanism to track how often children are medically screened within 72 hours, and we were able to, with education and training, actually go from 17% in 2013 to 63.5% of the time in June of 2014. That is significant, and it shows that our focus on screening these children gives us the ability to understand better where to place them. Where is the right place to put these children as quickly as possible, and what are the right services to give them? We also are working with Dr. Lewis of Marshall University Medical School. He has been doing a lot of research on what type of screening tool do pediatricians and family practice doctors need to have in place to understand what is trauma for children. What has happened to them, what does that mean for them, and what do we need to do for them to support children and to help them. The tool will be initiated in physician residency clinics by the end of the year. We're very excited because he's partnered with the American Academy of Pediatrics. And once the results of the pilot are obtained, it's possible that the tool that we use in West Virginia that we have piloted could actually be used nationwide. Pretty exciting opportunity for us here in West Virginia to show that we are state-of-the-art, cutting edge, and doing the right thing for children. The other area that we focus a lot of attention on, and I know you're very familiar with, is the issue of neonatal abstinence syndrome. We have many children born, sadly, in a situation where the mothers have taken drugs, and we have to continue, the babies are born drug addicted, and we need to figure out what is the best way to manage or help families, work with foster families, whatever it takes to ensure these children get the best possible care. Now, we did a couple of things. First thing we did is we got to track it. We can't understand it till we track it, till we know how many babies there are. So we actually initiated a web-based reporting tool. So now hospitals are required, this just started, so of course we don't have all the data yet, but hospitals are required to report the number of babies that are born with neonatal abstinence syndrome. That's going to give us data. Data is important. We can't make decisions if we don't have good data to actually know. Anecdotally, many physicians, hospitals will tell you a large percentage of the babies that are born do have neonatal absence of syndrome because of drug addiction in the mothers, but we don't know the actual number yet. So this is going to help us do that. The other thing we've done is some surveys. We're trying to understand from pregnant women and postpartum women, what are the barriers to accessing treatment? I mean, we need to stop it before the babies have neonatal abstinence syndrome. So we have to understand what is preventing you, if you're the mother, from seeking treatment. So we are working with WVU, Dr. Chafin from the Jones C. Edwards School of Medicine and West Virginia Perinatal Partnership. We're compiling a survey data, and we're trying to understand, and we'll be more than happy to share that data, what prevents you from accessing treatment. Because we want to stop it before the baby's born, not necessarily after. We did do a pilot. It's a very interesting pilot. We're pretty excited about it. Lily's Place. Some of you may have seen the grand opening for Lily's Place. But it's a 6-month pilot with the Bureau of Children and Families where we are working to support healthy babies and families. Now, how are we doing that? Lily's Place really allows us to spend time educating the mother or the foster parents or potential adoptive parents, whoever it might be, on how to care for these infants because they're special and they need special handling. And so they do that. We talk about therapeutic handling of these babies. We talk about weaning techniques to ease the discomfort that the babies have. We talk about a non-judgmental counseling approach, supporting, trying to understand what was the situation that led to this, and what is it that we can do to support families, keep families unified whenever possible, and if it's not possible, create an atmosphere where foster families or adoptive families can be successful. What we see now is that these babies can be very challenging to manage. So if put into a home prior to learning and educating themselves about the babies, how they act and how they eat, then sometimes they're not able to care for them. This pilot gives us the opportunity to see if it can work with using a method where the babies we work with the babies, we help wean the babies, but at the same time we're counseling and working with either the mother, biological mother and family, or potential foster parents or adoptive parents. Key is coordination. We have to work together to try to do the best thing that we can for our children. Again, part of our 3-branch institute focus. We officially opened October 1, and I think currently there's 4 babies in Lily's Place. The other thing that we did as a result of the 3-branch institute is we realized that we needed accountability. We have to understand, what result do we want? What do we want to get to? How is it that we can change things if we don't work our way backwards? If we don't start with, this is the result. The result means we want to reduce the children in out-of-home care. We want to reduce the children in out-of-state placement. We want to bring children back into a family environment whenever possible, understanding, again, the safety is number one concern. And so it's starting with the end and working our way backwards and training our staff to think that way. Our goal is sort of a call to action, using plain language, saying to ourselves, here's the result. Now all of us work together to figure out how to get to that result. We are training all of our Bureau of Children and Family offices in the results-based accountability. We're training our providers in how to identify what is the result we want, how are we going to be accountable, and working our way backwards to the actions that need to take place to ensure that we're getting the results that we need. And we've trained a team. We're going to actually partner with some of our other bureaus in DHHR and train them on this methodology as well. This is our great accomplishment that we're very excited about. Part of the 3-branch was to think about, how do we serve children differently? Now let me tell you just a moment about how the federal government pays for services for children. It's quite interesting. They pay for services based on out-of-home care. All right, if the federal government under 4E pays for out-of-home care, how do we think about keeping children in a home-based environment and doing wraparound services for those children? I like to think about wraparound services as wrapping my arms around the children. You know, we're here to love you and care for you in a home environment whenever possible, yet we have to be fiscally responsible, don't we? There's a cost to caring for these children, and quite frankly, the highest cost is in residential treatment. Yet the government federal government primarily pays for out-of-home care. So how do we look toward keeping children safe at home and figuring out a way to reimburse for wraparound services? The only thing that we could figure out that we could do was apply for a waiver. This is a demonstration project. We had to quickly apply for this waiver. It was actually sort of odd that I came on board in July of last year and we said, oh, this is a waiver, but people have been working on this waiver for a year. There's probably no way you can get this waiver. And we said, oh, well, we are going to give it the West Virginia try to make it happen, and we did. So we are very proud that we were able to put a team together. My team is here and really want to acknowledge the work that they did to put the waiver application together, to work closely with our federal partners, and they gave us a yes, you can be part of the demonstration waiver. We know that's going to have a huge impact overall on our ability at some point in time to pay for wraparound services in the community. But I'll remind everybody it's a one-year implementation period. So during that 1 year, we will still do our normal claiming of 4E funds from the federal government, but we will get some additional funds to implement our program that's targeted at 12 to 17-year-olds, and I'll talk about that just a little bit. The idea behind it is to pilot it in certain counties. There's 14 counties that were chosen, and the goal would be to get children out of congregate care whenever possible and either reunite them with their family or with whatever that family unit might be, whether that's biological parents, foster parents, adoptive parents, whoever it might be. The idea is to get them home. Now, we can't get them home if they have a behavioral health problem without services, correct? So again, the wraparound allows us to pay for, at some point in time, once we work out all of the details, services in the community rather than in a congregate care or residential treatment. So it's very exciting to us. Now, what is our vision? Our vision is we call our project, you will not hear us talk about it as a demonstration waiver for 4E funding any longer. You will hear us talk about our project as Safe at Home West Virginia, because that is what we believe is critical. That our children, as many of you know, we have children in out-of-state facilities that we would like to bring home. We have children in residential treatment that may be better served at home with wraparound services. And so our job as the Bureau of Children and Families and DHHR is to really think of what is the permanent connection that these children need to have with their family and their community. Now, how are we going to do that? Lots of ways. Reunification, adoption, legal guardianship. All of those are goals of our Safe at Home West Virginia project. But we want to have children who have a caring adult in their lives. That is what's important to children. That's what supports them and helps them become successful. We like to think of it as sort of the three aims that we have for our children. One is safety, one is they will be healthy, and third is they have the ability to be successful in their lives. And that is our focus. We want to, of course, first and foremost, make sure that they're getting the correct services, and we will ultimately guide that process through our implementation over the course of the next year. But the goal is total transformation. This is not something we've done in West Virginia before. This is something new. It's a new way of thinking about it. We believe it's going to produce a higher quality of life for our children, and quite frankly, it will do so at a lower cost. So all of this is a way for us to change the system and to really be focused on children and families. The targeted implementation date is October 2015. We are basing this on evidence-based practices that have been done in other states. It's the National Wraparound Initiative. This is something that other states have been doing. We're following suit. We're going to be engaging community support. What we learn from other states is the government alone is not the answer. It requires collaboration and cooperation from your community. People working with you to develop those wraparound services, whether you're in a rural community or you're in a more urban community, the goal is we're going to be able to serve you in the area where you live. It's a partnership. It's a new service model delivery. It will include assessments, care coordination, planning, implementation, but the goal is a single plan for the coordination of services for both children and their families. Now, what is the single, and we're going to talk about the CANS, but what is the single way that we coordinate activities for children? We have to assess the child. We have to assess the family. So our goal has been to implement a universal assessment tool. This universal assessment tool gives us some information. It doesn't replace existing tools. I mean, there are tools out there that assess children that we have to keep in place. That's necessary, especially if it's specific behavior disorders. But we want to put in place a universal tool that will follow the child no matter where they go, so that everybody has the same information about the child. So it really is, the CANS is a safety risk assessment. We'll continue to do family functioning, youth risk assessments, care plans. But the idea is that CANS isn't going to diagnose a problem. The CANS tool is going to tell you what are the strengths. What are the good things about the family that we can build on to try to help those families? What are the things that are jumping out at us that we need to all be aware of, whether we're a provider or we're a case manager with the DHHR, or we work in the court system? It doesn't matter. At least a universal tool gives us the basis to understand what's going on with that child and their family. Now, what does it do? The CANS decision-making tool, we're very careful about. We use CANS, and the reason we use CANS is because we work closely with Dr. Lyons. It's an evidence-based tool. We think it's really appropriate for West Virginia. Many other states have implemented this tool. But the bottom line is what we're looking for is universal assessment. What will universal assessment tell us? What are wraparound services the family needs? What are the service gaps that we need to look at in the communities? And we know there are service gaps. There are places where we don't have yet the infrastructure to take care of our children in their community. And we've got 1 year to figure out how to make that happen. And we're going to do that. We're going to be focused on it, and we're identifying gaps as we speak today. What kind of support's needed to maintain children in their community? We all know if you work in the education system, children do better if they're in the school where they started. If you uproot the child and you move them to a different part of the state and you put them in the school, what do you think is happening to that child? Not only have we uprooted them from their family, we've also taken them away from their teachers, their friends, the people they know. So the idea and concept behind keeping them close to home and keeping them in their community is holistic. It's not really just about their health and well-being as a foster child. It really is about how do we focus generally on all the things that are necessary to make a child successful, which includes the education system. And we know that we only do out-of-home placement when it's absolutely necessary. And that's the way that we'll focus our attention. Now, the West Virginia CANS is a document or an assessment that we believe is critical to our whole program. Our implementation of our wraparound services has to have a basis. We have to have that universal assessment tool. So we have already started, even before actually we got the waiver. We've decided we're going down the path with or without the waiver. We're going to make some good changes in Bureau of Children and Families. And so we've already started educating people on the use of the CANS document. We have done online training. We've done really CANS, West Virginia CANS across our whole Bureau. We have a partnership with the university. They're working with us. We've trained providers across the board on how to use it. We are now looking at how we will use the tool to measure the effectiveness of any programs we get put in place. The key here is we must measure outcomes. You saw our outcomes earlier, right? You saw where we fared with other states. We've got to change that. So we've got to create measurements that will help us know if we're moving toward our targets. We believe we can do that. We'll need the help of an evaluator who will actually give us some of the needed and necessary tools to know how to measure step by step and how we're doing sort of step by step as we implement our program. The goal is really to automate at some point in time our CAN scores, do an analysis of what does that mean about our children and families in geographic regions of the state. I think you would all agree with me we would find different things, right? Whether we're in the northern panhandle or southern part of the state, there's going to be geographic difference, cultural differences that we need to take into account when we plan and decide what are the right services for this family and these children. So our goal here is to create a way where there's guided decision making that's specific to the child and the family. No longer do you just put a child in a program because that program exists. We think about what individually does that child and that family need to create an environment that makes the child, again, safe, healthy, and have the ability to be successful. And that is our ultimate goal, working our way backwards. Those are the outcomes that we want to see. The one thing that I will share with you about the three-branch institute, our waiver program, and the use of a universal assessment is that all of this is done because we care about the children and the families in the state of West Virginia. And we have recognized through our statistics that we're not where we need to be. And so we're going through a process of change. Change is sometimes challenging. It will be a rough road at times for all of us. But I can tell you from our bureau, we are committed. I can also tell you the providers are committed. And the providers understand the need to change. And so I believe because we have all three branches of government represented and because everyone knows there's a need for change in West Virginia, that the stars are aligned and the time is right to do something significant for our children and families. And I'm very proud of my team and very proud of what we've been able to accomplish to date, but I look forward to being able to come up and share with you some more information as we continue with the implementation process. Thank you.
Thank you, Madam Secretary. I find very interesting one thing that you've done, increased placement in 1 year from 17%, the screening, thank you, 17% to 63.
Thank you.
That's a great deal.
Thank you.
That's a good
A lot of
job.
hard work. Thank you.
Yeah, that's a good job. Is there anyone who has any questions? Yes, sir, Devon?
Thank you, Madam Chairman. It sounds to me like you're trying to develop a system here where one size does not fit all, which I certainly agree with. If you would expand a little bit on page 14 of your presentation, you use the word cultural differences between areas of the state.
Mhm.
So in this effort of not having a program where one size fits all, would you expand a little bit on what you mean by that and how you plan to address those differences? And maybe what do you all see as those cultural differences?
I'll speak to your first question, which is what are cultural differences? What we understand about the state of West Virginia, if you look at our current statistics, and we look at regions of the state, what we understand is there are certain regions of the state where children are more likely to be placed out of the home. There are certain regions of the state where children are more likely to be placed with kin versus foster parents. There are different parts of the state where the demographics would indicate, we know there's child poverty throughout the entire state, but we also know in certain parts of the state there are differences in terms of whether there's a working parent or not. So all of those things really have to be factored into how we create an individual plan for the child and their family, because if we don't understand, as an example, I'll use kinship as one example. If we don't understand the the tendency, which is a good tendency, to put children in with families where they receive support, if we understand why that occurs in one region of the state, then it will help us understand how we might be able to facilitate that in other parts of the state, or if not, what are alternatives to placing children, if not able to keep them in their home, which is the number one goal, permanency within their home. What are other alternatives that are acceptable that will still meet the child's needs? So I think the demographics of our state is different. I think we have to understand those demographics, which leads to some cultural differences that we currently see. And understanding those will help us address how we go about servicing children in the community. In addition, we have some communities in our state where wraparound services already exist. People are already, putting their arms around the children and keeping them as much as possible by using mentoring or other programs to keep children in the homes and working with the families. In other parts of the state, we don't see that. So it really is a way to collect data to understand a little bit about how we plan programs that are specific that will help us, because one size does not fit all and will not fit all, and quite frankly is not really the most effective way to care for our children, and we have to understand those differences before we can plan to create the right environment for the children and their family.
Does it make it, I guess, first of all, I would be concerned that people down the line from you are buying into a new way of doing things, which is always pretty hard in any organization, particularly a government organization. But do you see any difficulties when you're trying to structure a program and you have managers, particularly maybe in a Wheeling area, that are looking for guidance from the manager in the Beckley area, and you're doing things totally different? And what are the aspects as far as the legal ramifications if you handle one case up here this way, but you've handled another case down here this way?
Well, let me speak to that. First off, let me say that we have had huge buy-in from our staff. I mean, I can let Commissioner Exline speak to that, but they were ready for a change because they recognize the system that we have in place isn't working. It isn't doing what we need it to do, which is what people go into our business to, which is take care of people. You don't go into DHHR for other reasons. You go into it because you want to be there to help people and to make a difference in the lives of the people they serve. There will not be a legal issue because what we will be doing is individualizing care, but we will not be not providing a service to a particular area of the state. Our goal will be to individualize the service to make it work for that particular area of the state. The Governor's Advisory Council on Substance Abuse is a great example of that. Task forces throughout the state of West Virginia came up with what does that region of the state need, and they brought that forward. And many of those recommendations then were put out by regional directives because that community bought into the idea of this is what was needed in the community. The same sort of concept applies here. We've got to figure out what's needed in that community to serve the children, and if we're serving the children in the right way, there will be no legal implications because we're going to be doing the right thing for the children.
Is there any other questions? Senator Laird?
Thank you, Madam Chair. Thanks for your presentation, Madam Secretary. Congratulations to the Three Branch
Thank you.
Institute. I think this is the best work for the benefit of children and family I've seen in a long time.
Thank you.
I have a question concerning the Title IV waiver program. Obviously, that's being run as a pilot in 14 counties. What criteria was used to decide which 14 counties this would be run, I guess, as a demonstration project? And is it likely to move from a demonstration project to all 55 counties? And for my benefit, I have no sense of dollars. How much 4E, what money does West Virginia receive in the aggregate, and how much would the waiver break away from those total dollars for these programs?
Thank you for your question. I actually should have addressed that during the presentation. the idea behind this is when we get, this is a 5-year project. By the time we get into year 5, it will be statewide. The suggestion from the federal government is to take it in a pilot form so that we can tweak it. If it needs to be changed, we need to do things a little bit differently for the implementation statewide. What I want to tell you is the goal of this program for us is that we can actually improve quality and reduce cost and then put that additional money back into prevention, which is where it needs, as we all know, where it needs to go. We need to prevent children ever being removed by supporting families and helping families. And so the whole demonstration waiver is really targeted around pilot, then statewide, and then whatever savings are left from the statewide implementation, we will put back into the front end, which will be, of course, the prevention services. Now let me talk about dollars. Here's where I'm extremely proud of the work that we were able to do. Some of you may know that because we received federal funds through the 4E waiver, that at the end of 2011, we were the worst claiming state in the United States. I am proud to say, as of today, we were at not quite 10%, we are at over 50% at our claiming. That is phenomenal. Again, a tribute to my folks out in the field and the people at BCF. What that did for us is that allowed us to negotiate with the ACF, which is the Administration for Children and Families, to receive a higher rate over the course of 5 years because we were able to convince them that the rate would continue to go up, because in their prior demonstration projects, they went back 3 and 4 years, and if they had done that, we could not have done the waiver because there would not have been enough funds to provide the wraparound. But because we explained to them that this should be our claiming year, base year 1, over time, we will have over $260 million. And that's the most that we have ever had in our system for this service. Only because we were able to negotiate and explain this had to be year 1 for the ACF. So we're very proud that we were able to get a significant amount of funding to implement this project. Thank you.
Thank you.
Senator Goodman.
Thank you, Madam Chair, and thank you, Madam Secretary, for being here and for the work that you've done. As you know, I introduced legislation in the last 2 years to make CANS a uniform assessment tool, and then later talked with you, with the assistance of Senator Stallings, concerning the implementation of this tool. And so I'm pleased to see that it is actually being implemented. Can you tell me when it will be finally implemented, fully implemented throughout?
Yes, sir. Be more than happy. And I know that you have had an interest in this, and this is important to you, and I'm sure you've been excited by hearing our discussion today. What we discussed, you and I discussed it, and as well as with Dr. Stallings, is that our goal was to really develop a cooperative spirit about implementing a universal assessment tool. We did not want to put in a statute or in a rule that it would be the CANS document, because over time things change, and we very well may want to revise that tool, or another more evidence-based tool may come into place. Right now we believe the CANS is the right tool for the universal assessment. Dr. Lyons will be back in West Virginia in December and will finish our training. At that given point in time, all of our staff as well as the providers will be trained in the use of the West Virginia CANS, because we put some unique questions in it that's specifically related to West Virginia. The only, right now we're calling it a universal assessment tool. We are working with the Division of Juvenile Justice, who is not yet committed to implementation of that as part of what they do. But we're still working with them on that project, but we have everyone else on board and in the process of being trained. We believe shortly after January 1, it will be in full implementation.
Great, great. Thank you very much.
You're welcome.
Thank you, Madam Chair.
Are there any questions? Barnes.
Thank you. Just one more question, and I can't help wondering, looking back at the chart you gave us on page 2. Just wondering, and I'm kind of a student of statistics, and if you don't know this, that's okay. We can run, our people can run this ourselves. But just wondering whether there's a relationship in this progression as you go along this chart to the number of families needing to receive public assistance in each of those states. Do you know if there's a relationship here? If you all looked at that.
I cannot speak to this. This was data provided to us at the Three Branch Institute, so it was something done by the NGA or one of the national associations. What we do know is that we did actually talk to some of the states in the higher categories to try to understand exactly, what might be some similarities in the case. Many times it is a significant population of people that live in rural areas, and there's a lack of services for wraparound. And so what we found, as at least in discussion, commonalities with some of the states was more related to how you can obtain services in that state. I can't speak to the economics of it, but I can speak to the fact that at least in discussions, there was certainly a lot of, close association with, how do you serve people in a community, and, do you have the availability of services? And, to speak to the judicial system briefly, if I may, many times that children are put in residential treatment because there is no other option. And our goal is to give them an option. So right now, while we see a large number of children in residential placement, it could very well be the result of the fact there aren't services in the community. I believe we can change that.